Right. Hello, everyone, and happy Friday. Thank you all for joining the April PFCC Partners Community of Practice workshop. I'm very excited to see you all here and very excited for our presenter today. Today we are joined by Christina Motti, who is the Senior Manager at California Quality Collaborative and Purchaser Business Group on Health. And Christina is joining us today to talk about the movement toward behavioral health, and we'll share some of their behavioral health integration, and we'll share some of their new curriculum today. Before I pass it over to Christina, I just wanted to quickly reintroduce our organization for those who might be new here. I am Lindsay Galley. I'm the Director of Education at PFCC Partners. At PFCC Partners, we have a mission to center the inclusive experience of health and reinvent through radical collaboration and be a catalyst for system transformation as well. And in the future, our vision for the future is a health system transform, and one that works with people and through communities as a partner in their well-being. Our values include equity, inclusion, diversity, collaboration, and being able to be solution focused. We, through those values, also host the Patient Family Advisor Network, or the PFA Network, which is a community of patients, families, family caregivers, all using their lived experiences to influence healthcare improvement. As part of the PFA network, we have multiple engagement opportunities from healthcare organizations across the country that come to us looking to actively engage patients and family caregivers in their improvement work. We have a large community of patient family advisors, really a peer community to learn from one another, and skills development opportunities as well, a chance to build skills as a patient family advisor and learn from others in their role. So if you are a patient family advisor, we'll put the link in the chat and you are welcome to join our community. Before I pass it off to Christina, I just wanted to make a few notes about our presentation today and using Zoom. So I know we're all quite familiar with Zoom, but as the presentation is going, if you could please mute your lines. If you have any background noise, that is really helpful. And then we have plenty of time for a Q&A at the end of our session today. So if any questions come up during the presentation, please feel free to put your questions in the chat and we will make sure to get to those at the end of our session today. You are welcome to turn on your video as well, share your smiling faces on this lovely Friday. And yeah. Thank you again all for joining us today. And with that, I will pass it off to Christina Motti. I will stop sharing first. There you go.
Thanks so much, Lindsay. So let me confirm right now that you are able to see a PowerPoint slide that says moving towards behavioral health integration.
Looks good.
All right, super. Well, thank you so much for having me today. I hope you all pardon the pun, but PFCC Partners has been great partners to my organization, PBGH, the California Quality Collaborative, for many years as we've been driving improved patient engagement in our quality collaboratives. As Lindsay was saying, thank you so much for joining us for today's important topic. We know that you're extremely busy, and also this day happens to fall on what might be many spring break, so appreciate everyone joining today. I'm excited to get to know those in the network, and I want to say that this presentation is meant to be interactive, so I hope that you feel comfortable sharing in the chat if possible, but if you're also welcome to come off mute and share if you're in a place to do so and feel comfortable. So because I'm new to this particular group, I wanted to actually do a poll and hear where everyone is coming from, both geographically and then what perspective that you represent. So Lindsay is going to help, and thank you, Lindsay, help me take that poll, but run that poll. So when you get a moment, please answer from where are you dialing. I happen to be dialing from Northern California in the East Bay, where we've had some really nice rain, some April showers that were surprising, but always welcome. And then I'd love to know what perspective you represent. And is it the patient family, a provider practice, health plan, government agency, technical assistant organization, a research agency, or if it's something else not on the list, feel free to put that in the chat. I happen to work for an organization that provides technical assistance, and I'll describe it in just a moment. So I think that we're reaching close to final, so maybe, Lindsay, if you wouldn't mind closing the poll and let's share the results. I love to see the geographic diversity in the room. Looks like the network is all over the country, and we might have a slight lead from the Midwest. And that's always fascinating to me because we speak to an oftentimes mostly California audience. So really excited to see all of these voices and faces from across the nation. And looks like, what perspective do you represent? Looks like it's mostly patient family, and then we have some other in there. So thank you for putting those in the chat. If you a hospital association and perspective combo. Yeah, Nancy, great point. You couldn't select more than one. So patient, caregiver, group advisor, and a quality improvement organization. Well, thank you so much. I think we can stop sharing those results, but really appreciate you taking the time to let me know a little bit more about where you all are coming from. So a little bit more about the organization I work for. I work for the California Quality Collaborative, or CQC. We are a multi-stakeholder program of the Purchaser Business Group on Health. We bring together different organizations in the healthcare system and also provide technical assistance that promotes quality, efficiency in the outpatient delivery system. I am manager of care redesign. I work on one of our ongoing learning collaboratives as a lead for our learning events. And I was one of the primary authors of the behavioral health integration curriculum that I will be sharing later today. So, what are we going to be doing in our time together today? First, I hope that we can all identify what behavioral health integration into primary care looks like by the end of the webinar. I also hope that we are able to share some personal experience around receiving behavioral health integration. And then I'd like to spend some time so that you all can better understand some of the resources CQC has developed for supporting behavioral health integration into primary care. So let's start out. What does behavioral health integrated into primary care look like? I'd like to start with a poll, another poll. So Lindsay's going to help me out again here. Thank you, Lindsay. How often does someone from your doctor's office ask you if you've been feeling down, depressed, or hopeless? Every visit is one answer. Sometimes is another answer. Never. Or you just can't remember, which is totally fine. I don't know if I'm not sure if I would be able to recall at this point too. So let's go ahead and give a couple seconds for folks to answer that question. And again, if your answer is not on this Zoom poll, feel free to chat it in. Okay. It looks like Lindsay, you started sharing the results. Perfect. Looks like we have a mix of answers that about 50%. Oh, sorry. About 50% of folks say that sometimes someone from their doctor's office asks. About 30% say every visit. 17% say never. And there might be one more vote for never in the chat. And then at least one person couldn't recall. Thanks very much for sharing that information. We're going to be talking in just a second about how screening for these elements is a key part of behavioral health integration. Right now, we're going to share two scenarios. And I'm in this first scenario, you're going to see a patient who's coming into his doctor's office. I'm going to give you a few seconds to read the cartoon on your own. And then I'd love for you to put in the chat what jumps out to you about this first scenario. Jennifer, thanks for kicking us off. The patient was never asked. The doctor just read reports and made her determination from there. Marty, excellent point. There was no two-way communication. Sarah, thank you. Yeah, the patient didn't feel comfortable to share. Any other observations about this scenario? Yeah, sounds like I hope I'm saying this name correctly. Salome, we're making assumptions about healthcare in this scenario. Well, thanks for taking the time. Oh, Nancy, great point. If I felt rotten, I might have canceled the appointment. Yeah, that's a big deal. So making it to the appointment when you felt rotten, that was actually a significant investment. We're going to move on to a second scenario. This is the same patient, but it's a different care experience. So I'm going to, again, give you a minute or two to look at this scenario cartoon. And please put in the chat what stands out about what's different between the two scenarios. Jennifer, thanks for chiming in. The provider asked and offered up the connection for help so the patient was lost in what to do. Love how the doctor integrates mental health in a general doctor visit. The doctor took the lead to ask and connect the patient with help. Yeah, optimistic and then unrealistic mood then. These are all wonderful observations. Some things that I would note that are a couple more from the chat. The patient feels heard and has an idea of what's next. Excellent. Yeah, exactly, Angela. And JR notes there was a process in place to ask a patient about the struggles and be able to speak with someone at the same location for improving the experience for the patient. Yeah, I think you guys have really honed in on what the difference is between the scenarios. In scenario one, the patient came in with a problem, with something that was weighing on his mind, and was not asked about it and did not feel like he could bring it up in that scenario. Scenario 2, the patient came in with the same sort of heavy feeling, but the doctor actually took time to ask. And the patient was able to share. And in that moment, in that actual visit, the doctor said, "Hey, I can match you with some resources right now." That's really a core. So a core function of behavioral health integration is behavioral health screening. When doctors or other members of the care team ask questions about depression or anxiety, it can be a routine process, and it helps them better understand what your needs are on depression. Once they ask the question, they're able to better match patients with the resources that they might be looking for. If you're one of the people in the poll that said your doctor has never asked you about some of these areas before, screening can feel new and sometimes even awkward, but it's really essential for your doctor or members of your care team to ask on a regular basis to understand what's happening in your life, because life always changes, right? How you feel a year ago is maybe not how you feel today. And so screening, which is demonstrated by this scenario 2, just screening for depression in this case, it's the first step in moving to what we call behavioral health integration in primary care. Are there any other questions or thoughts on these scenarios? And feel free to add in over the chat as you have been doing, or even come off mute.
Sometimes I feel like those questions are somewhat minimalized, or, it's that I've many times, and we got to ask these questions, we do it every year, and it just kind of makes it seem like it really isn't important versus being open and, just explaining a little bit. I mean, some assessments and answering those questions is new, and it can be a little, I don't know, overwhelming, and, patients are a little leery, to be honest. And I think it's how it's approached and how it's laid out, and how how you can engage a patient from the get-go about of assessments that is so important. I think it's sometimes kind of basic but overlooked.
Angela, that's an excellent point, that it's not just about the asking, it's about the how. And building on what chat, acting like it's a standard question means that you know that this is part of routine care. That's important. But I think that, Angela, you're also bringing up a good point, that how the question is asked, the background that patients and family members are given around the question, that's also super important and should be part of the training screen. The screening training that anyone that asks those questions should be given. Okay, well, we're going to keep going then, sharing your reflections on these two scenarios. I would just like to acknowledge that there's a couple other reflections that come in the comments. So thank you very much for sharing those. I'm going to move on now to a little bit more of some definitions around behavioral health integration, also known as HI, because we can't leave an acronym well enough alone in healthcare. This definition is from AHRQ, and they define behavioral health integration as a patient experiences as a result of a team of primary care and behavioral health clinicians working together with patients and families, using a systematic and cost-effective approach to provide patient-centered care for a defined population. This care may address mental health and substance abuse conditions, health behaviors, including their contribution to chronic medical illnesses, life stress and crises, stress-related physical symptoms, and ineffective patterns of healthcare utilization. So the takeaways that I would stress from this definition is that the primary care team linked to the behavioral health team. Ideally, that is supported by warm handoffs, like that happen in the doctor's office, and data sharing. So each care team knows what patients and family members are going through. The other thing I'd note is that behavioral health in this context can mean a lot of things. It can include mental health, substance abuse, health behaviors, life stressors, and they can also be new things or ongoing issues that patients have been dealing with for a long time. The other note that I would say about integration is that in practice, what it looks like at an actual doctor's office may be different, very different, and will depend a lot about how your doctor's office has been able to structure the integration of care. So I'd like to share, walk us all through an example workflow. So this is how, think of the patient cartoon scenario that we walked through. And this is a similar, might be flow looks for the second scenario. In a doctor's office, a patient might take a screening questionnaire, like our patient in the cartoon. If they didn't share any behavioral health needs, the visit might not look that different than the standard visit for whatever they came in to treat. Patient did share needs, their provider will screen, and then we'll talk about the results for you. And in this example, they introduced the patient to a social worker who will talk with that patient, ideally the same day as the visit you already came in for, and decide on some treatment options. The treatment options will look very different based on the needs and also the resources that the doctor's office is able to provide, but they could include short-term therapy, group therapy, community resources or referral to specialized services, coordination of population health, connection to internal psychiatric resources that include medication support, patient advocacy, and crisis intervention. Again, in this scenario, the patient walks out of the visit with a care plan for addressing the behavioral health needs that they walked in with, and they know what to do next. I would just note, because I saw both in the chat and then Lindsay was explaining to me some of the network makeup groups who work more with hospitals. Hospital integration around behavioral health is specialized. Today, there's more of there's actually a lot of work that's happening in emergency departments around improving interventions around substance abuse. Many hospital visits may end with a visit from a social worker to understand community needs after discharge. But I want to say that what we're talking about today is integration of behavioral health into primary care. And I would say that more work could be done around integrating behavioral health into inpatient and emergency care. So any questions about the definition of behavioral health integration or the workflow that we shared here? I'd like them to open it up to see, now that we've talked about integrated behavioral health, I'd love to open it up and hear from the group. If you haven't shared, how have you experienced integrated behavioral health care? And what would you like to see around integrated behavioral health care? Looks like Nancy might have a comment about availability being an issue, which might definitely be true. We're going to talk in a moment about the how behavioral health needs are very hard to be met across the country.
Do you want that comment later or now?
Now's good.
Okay. I've been on some medication long time for something diagnosed not quite well a long time ago. And I was wondering about tapering, and is, the situation disappearing since there's been no recent episodes. And it's like, okay, we'll schedule you over to talk to so-and-so, but that was probably the Tuesday of the following week. Long story short, I didn't have the new time on my calendar, so I ended up with a brief phone conversation with a person I was not willing to reschedule at the time. So it's unfinished business. We have a shortage of medical people in New Mexico, all medical and psychological people from soup to nuts. So it's part of dealing with things. And the scheduling in general is another topic I'd like us to address sometime, not specifically associated with behavioral health, but that's a trigger for later.
Yep. No, Nancy, I think that's an excellent point, that the shortages among medical staff are even more felt even more for behavioral. There are shortages, definitely in California, the state that we work in, but I would imagine across the nation, and it becomes harder and harder to find people who can work on site to make interactions like the one that you described even easier. So it is an ongoing problem, and thank you for sharing. Oh yeah, go ahead, Angela.
Oh, no, I was just going to say, my experience as far as, just the different models and approaches and having a lot of rural practices that don't have a lot of resources, for behavioral health therapists or, anything outside the PCP clinic, they can work if those relationships are built. And, I feel like I spend a lot of time just helping primary care clinics that are wanting to integrate, understand what's already in their backyard that they've never had to tap into. And it's not, they don't know what they don't know. So I think sometimes it's always good to start and assure them, because I do think primary care providers do have so much on the plate when, they're the front line for so many things, especially with, the youth and just the increased, rates of depression and anxiety. So I know the best scenario is to have that warm handoff and make that in a safe place. But when that's not possible, I think the collaborative care agreements and reaching out and understanding what's in your community, understanding what those referrals look like, because again, that's a daunting task, to get a list of referrals in the community here, give them a call. And that a lot of patients go home and don't, because it's hard, but I also think what I'd like to see around integrated behavioral health is really ensuring that there's buy-in from everybody in the clinic, especially if they're a new primary care clinic that, are just beginning to, maybe hire clinicians, but understand that, the cultures are kind of different, and respecting each other's approach and expertise and working together as a team, because I often feel too that patients are in the middle of trying to, well, this is what my primary care said, and now you're saying this, and who do I go with? It's always difficult, the patient in the middle. Who do I listen to? But I just think to start to have a great foundation for great true integration, it's really getting the understanding that the entire clinical team, front desk to coders, to understand what that means to them, as a clinic, and where do they fit in that link? Because it takes a team. And some of the practices that I've, coached and the practice facilitation with, those teams that are so open to each other's thoughts and ideas and suggestions for clinic workflow and, patient feeling safe and secure to share, they do amazing work, because it, again, it truly takes a team. And I just think starting off with everybody understanding their role and how vital it is, to meet, patients where they're at and support them and at whatever readiness of change they're ready to go to, is really important. So that's what I would like to see more around integrated behavioral health. It's just really encompassing and integrating everybody in the team, so everybody understands what role they play to support patients.
Yeah. Oh, Angela, I think you bring up so many excellent points, and I'm just going to piggyback on a few of them. The first is that, behavioral health integration is not, it's a gold standard, but it's not easy work. And it's even harder for primary care practices that are smaller, that are under-resourced, that have been dealing with pandemic effects for so long. So they supported and better supported in having the resources to a well-resourced list can refer out to if they're not able to take on behavioral health integration internally. We talked about the importance of behavioral health screening, in just asking the question, but it's never just, because if a practice takes on, if a doctor's office takes on asking questions about depression screening, they need to be able to know that they are going to be able to refer patients out if they can't take care of the treatment inside their own four walls. So I think that you're bringing up a lot, that like there's so many places, the need is there, and many practices kind of want to do the work. But the other thing I heard you say, which is definitely true, is that behavioral health integration is a culture change, because you're bringing together two different types of providing care, and the care teams have to do things differently, from soup to nuts, from screen registration, from data sharing. So this is not an easy process. It's better for for treating whole person care, but I'm happy to report that there are resources out there, and I'm going to talk about ours in just a moment. I do want to just Angela, did you have additional thoughts there before I kind of look?
Nope, I didn't realize I was unmuted, so thank you.
Yeah. Let's see. Lisa mentioned, I would like to locate a list of primary care practices with integrated health by state so I can assist my community with triage. I agree. I don't know of such a resource. I'll ask my colleagues if they know of one, but I think that would be a fantastic resource to be maintained, if not at the state level, at the national level. It looks like there's a question from Ting. Where do you draw the line for the PCP? Would someone who feel depressed call the PCP for an appointment just like any perceived medical problem? That is the model for assuming that the doctor's office that you go to does practice behavioral health integration. You could use the primary care physician as your door to get treatment. Yes. And another note for the dialysis population, there's much concern about stigma around mental health, and referral to the PCP can mitigate that. Yes, I love Lisa, and would just say it's different stigmas probably exist in different populations, around rural, around smaller communities, and so I believe there have been studies shown that say that treatment within the walls of primary care can actually help address some of those stigma issues, and making screening a routine part, as someone else pointed in the chat previously. Well, thank you very much for sharing your perceptions and your recommendations. This group has a lot of wonderful thoughts and questions, so thanks so much for being so open with them. Right now, we're going to talk about how healthcare organizations can move towards integration. I certainly wouldn't call it lucky, but one thing that has been exposed through COVID is that the needs around behavioral health keep rising, particular to California, but nationwide as well. We've already mentioned that patients face limited access when seeking behavioral health treatment, because it's not offered. There simply isn't enough ways to get care in their area, or even via telemedicine, and that the needs have increased around mental health conditions and substance abuse since the COVID-19 pandemic. And I would say not just for adults, but in the pediatric population as well too. Another thing I would note is that more and more studies show that addressing behavioral health needs is not just improving your mental health, but to build on Nancy's comment in the chat, regular medicine, it improves the whole person. So integration improves patient outcomes and quality of life for the chronic disease management and other conditions. The last point that I'll make is that behavioral health integration is beginning to be invested in. Although a caveat that this is an extremely complicated space in California. If you are from the physician or provider office space, you should know that there are CPT codes for doing structured screenings. Many health plans are reimbursing for it, so providers should check what your commercial payers are reimbursing for. Medicare beneficiaries are covered for an annual depression screening, so it just is a matter of making sure that you're doing the right coding there. In the resource that in our curriculum introduce in just a moment, we do have included resources there. There's also more of a movement to actually reimburse for a model of behavioral health integration called co-located care. So since 2017, Medicare has been making payments around behavioral health integration services, but what other payers are doing is truly state dependent and payer dependent. So I don't want to lead anyone astray by giving you guidance. I just suggest that you kind of use the curriculum to get started and look into what might be your own state's or regional approach. What I'm going to introduce in just a moment and do a live demo through is a project that CQC launched called the Behavioral Health Integration Improvement Collaborative Curriculum. What it is an online resource that is guiding teams through 20 months of independent work across 7 project phases so that they can start or improve behavioral health integration in primary care. The curriculum includes self-directed virtual learning activities, curated resources. It includes the components that includes over the 7 phases include patient engagement, workforce, health IT, clinical and care models, data, financing, health equity, and sustainability. So if you can give me a moment and I can pull up that. Can someone confirm for me that I am sharing, that they now see the Behavioral Health Integration Improvement Collaborative? Should be.
Yep.
Yes.
That's good.
Super. So I'm going to walk through this resource, and it's totally free. It's accessible. I think the link was shared in the meeting invitation, but maybe Lindsay, if I could ask you to be so kind as to put in the chat. So there are several. You might imagine with 20 months of work, it's not a short document. I'm going to be perfectly clear, but it's meant to be really, really supportive of where healthcare organizations, meaning a primary care organization, might be just to start their integration journey. So we expect that a primary care practice that could be a health system or federally qualified health center could use this. Other organization types that could use it could be IPAs, MSOs, or ACOs. A coach or another improvement collaborative convener could actually use this as well. So a practice facilitator could actually help an organization implement this at theirs. And then I would say it's really for organizations at the beginning of their journey, of their behavioral health integration journey. So this section walks you through how to actually use it, but I will say this section might be important for practices that have not started anything. So there's several components that they might want to think about when if they truly haven't given a thought to behavioral health integration. So they might think about the financing opportunities. I mentioned some that there's resources around screening, reimbursement for behavioral health screening, as well as behavioral health integration. So these would be that they could take to better understand that landscape. Staffing, we've already talked about how it's very difficult to hire, but there are some resources for understanding what kind of roles they would want to hire and then where they might go to actually get those as part of their staff. And then there are some summary documents so that they understand what exactly is the scope for what my practice or organization would go through in the course of integrating behavioral health. So this is, I will just note too, for those that prefer to print out, there is a PDF version of the curriculum here. You're going to want, if you want to see all the steps, you can just navigate here and expand it. And so there, as I mentioned, there are 7 phases. Each phase, they add up to 20 months, but each phase is a little different for how long it is. So these would be steps that an organization would take at the very beginning. So they've done their pre-work, they've understand they want to take the journey, so they're going to assemble a team, they're going to review the entire curriculum just to see what they've signed for, and then they might start with a self-assessment tool. So you can, all of the activities for each learning activity are listed here, and then the resources that are going to appear as hyperlinks. So once I click it, the link would appear. They will be all included as resources here. So the next step for an organization might be to actually do the self-assessment and understand where their gaps and where their opportunities are around behavioral health integration. This last section is for, we built the curriculum so it could be used by a learning collaborative. So these would be activities that could be done as part of a cohort of learners. But I would say the curriculum can very much be used independently. So I'm going to then, one thing Lindsay was asking me to share was what might be a scenario of how an organization might use this curriculum. So let's think of maybe a small practice. Maybe this is an organization you work at or you receive care at. Small independent practice wants to launch behavioral health integration in primary care, but they really don't know where to go and have not considered this space at all before. So what I would recommend them do is start with that section, where to go when you haven't started anything, and review the steps around financing. So understand what might currently be able to be paid for screening or integration with their current payer mix. Understand their staffing. So do they have internal champions they could start the project with now? Should they start a hiring project that might take a while before they can actually do the integration piece? And then the entire project overview. And then what would be most ideal, but not always possible in every scenario, would be to have the assistance of some practice facilitator, improvement coach who could help them with starting phase 1. So when it comes to assembling the team and doing the self-assessment, as I was walking through, those would be the next phases of where an organization might go. So I'm gonna just stop right there and see what questions you might have around the curriculum or any other topics that we've covered in the course of today's session thus far. Feel free to join in the chat or come off mute if you feel comfortable.
I guess I don't really have any questions other than I'm super excited to look at the curriculum. It looks amazing. And I think another thing is ensuring that our voice, the patient voice, is heard, in implementing and feedback from, how it feels from our perspective as a patient, being introduced to a new clinician or workflows. I think a lot of times practices assume, folks will catch on, or everybody will know that, Mary's our, person that supports this. And I think that's an important piece. And I think also going above and beyond to engage not only the patient, but their caregivers and their loved ones. It's easy to hear and know what you need to do when you're in the doctor's appointment, but it's when you get home that you need the additional support and understanding that, if it's not shared with the family or caregivers, it's I don't know, it's easier to keep everybody on the same page and help, care plans go as, planned when everybody knows what they're supposed to be doing and what those around us can do to best support us when we're, seeking care.
I believe that was Angela speaking. That's who I said, but
Yeah.
Yes, I think that's an excellent point. And in the curriculum, we wove in the patient and family feedback pretty early in the project to understand what might be the perspectives on the needs, like where what might the integration model look like, as well as understanding what the workflow changes are. But agreed that it's never a one stop and you're done. It should be part of ongoing quality work for sure. Another comment in the chat: a good place to start integrating mental health is at medical school's curriculum. This speaker noted that they were lucky to do their studies at a medicine school where mental health and physical health are one. Yes, I think I'm hopeful that that's the direction that all medical schools might be going, because I agree that it's so important for every clinician to be well versed in at least asking questions and being able to be part of care teams that represent both behavioral health and primary care. Well, the journey is should start at the beginning, Nancy, as you put in the chat, and it can be a challenging one, but there are resources. So at this point, I thought we could all do a little brainstorming. We've covered what exactly behavioral health integration is, what it might look like from a perspective of someone going and receiving care, and then we've shared some tools. So I would love to, hear, how might you, in your role where you come from, support behavioral health integration? I have some ideas that you could, share the curriculum that has been put in the chat and covered in today's webinar with your network. You can continue highlighting the importance of behavioral health integration as a key change strategy for ongoing improvement work that you're a part of. You can continuously weave the patient voice into behavioral health integration projects. Here are some ideas, but the list is not done. What else would you add to this list?
I was kind of thinking too, because we have a lot of patient family advisors on. I'm curious your thoughts, Christina, on, how as a patient family advisor, or even just a patient, we might be able to promote or support behavioral health integration.
Yeah, a couple things come to mind. I mean, asking the organizations that that you work with what they do around screening, around depression screening, that might be a place to start. And maybe looking at ways to make depression screening more, patient-centered. I think we mentioned some elements about making sure that it's being asked in a way that feels respectful, and also that it's given the context so everyone knows why this information is being used. And then around behavioral health integration, I mean, that might be a question. We've mentioned that this is a strategic undertaking, but it might be worthwhile to ask the clinics and hospitals and health systems that you're part of to say, what are your plans on this? Have you thought about this? Is there some way that we could get involved and help? Those are two ideas, but I would love to know others from the wisdom in the room, the virtual room.
Can I ask a question? Have you done any study? Are the PCP ready to take on this task? I mean, even simple thing like like wellness screening, which is required in Medicare wellness visit. But my understanding is only about 30% of PCP actually asked.
You're right. Just starting with screening, no, not all doctors' offices do behavioral screening, or if they do, it might be for certain populations like Medicare, because that's biggest screening is reimbursed. So I do think that very much so that there should be a greater carrot to incentivize this integration workflow. So the point that I was trying to make around payment is that it is evolving. Payment for both depression screening and behavioral health integration, it's evolving pretty slowly though. So, you might try to do this work if you're a primary care practice, and the fastest way, I should say, I don't know if it's the easiest, but the fastest way might be to seek a grant from your health plan, a grant from another sort of nonprofit who could help support you getting, the boots on the ground kind of workflows in place and staff in place. That will hopefully change soon. And once I think the payment levers are aligned, as unfortunate as that is, hopefully the workflows and the change at the practice and health system level will happen. But you do make an excellent point that there is a sort of a gap in what's actually happening around screening and integration.
And I really do think a lot of that comes from not intending not to do those assessments, the fear of doing them and not having the resources. I mean, there's not a worse feeling than that. I think doing what we're doing today, the BHI curriculum, there are resources out there. I think, it just gets overwhelming, and it doesn't need to be if, we take a breath and take a step back. And, and I, coming from the behavioral health world and with lived experience, the cultures are so different. It's so easy to measure somebody's BMI and their blood pressure and their A1C, and boy, we were here and now we're here. How do I measure in an assessment how wonderful my mental health is? It's there. And so, one thing I always, talk to providers about is how we are mentally, totally, of course, right? We're one body and our mind is connected to that, improves A1Cs and blood pressure and weight and BMI, and understanding that, we can do everything right, but be on a medication that causes weight gain, and, and having some empathy for that, because it's hard. Med change is always hard. And then you get on a med, it works, but you gain 20, 40 pounds, So I think, again, the buy-in from the providers, assuring them that there is support there, but the investment on the front end of, looking for grants, increasing their care team, specialists, a patient navigator, peer support specialist, or they're just so vital, because everybody is busy, but it does take more than just a clinic team.
Yes, very much so. It's work that has to be entered on really intentionally. The worst thing I think that any clinician would want to do is additional harm. And so when it comes to adding depression screening to their workflows, the question you immediately have to ask is like, if there is a patient that needs immediate help, will I be able to serve them? And so that's sort of like the workflow mapping that needs to happen. Even if you're referring out, your care team needs to be able to know what to do if there is an emergent situation. So it's complicated, important work that needs to be better resourced, for sure. And I will say, I loved this note too. Another action item is, in our everyday lives, be more open about our struggles with behavioral health to normalize it. And I think that is an important point. And hopefully, webinars like this and opportunities to share with your network are good places to bring up that sort of transparency and authenticity. I I will note a couple of the recommendations: promote depression screening as universal screening, develop the value proposition to get buy-in from leadership and providers so integration becomes solidified into a long-term strategy. And then I love this suggestion to organize a focus group with providers who conduct screening and providers who do not conduct screening to discuss barriers and challenges to get more providers on board. So JR, thanks for those ideas. There was one question there about is the insurance industry, a lot of people determine any type of appointment by out-of-pocket expense. Yeah, that would be a question I'd have to dig into. I think that's really dependent on the payer, where the payer's market is. I know it really differs radically from payer to payer within California, so I imagine it does so nationally as well. I know we're almost out of time, so I would just want to thank everyone for your interaction and sharing today. I have a couple other resources I can share. CQC happens to be doing a webinar in May on behavioral health integration, one organization's journey, and then how exactly telehealth can help support integration. So that registration link will be shared. I can put that in the chat shortly. You have the resources of the curriculum. Encourage you to use it widely, share it widely, and ask me if you have any questions. And then I also want to share that CQC is going to be actually running a several-year learning improvement collaborative focused on behavioral health integration that will launch sometime in 2023. So if your organization wants to know more about that project, make sure to sign up for your newsletter, for our newsletter, and we'll make sure that you get notice about that. So with that, I think, Lindsay, I'll hand it over back to you.
Yeah, thanks so much, Christina. I think a really important conversation to bring not only to this community, but everything else that your organization is doing. So thank you so much for joining us and sharing this curriculum. And hopefully all of you walked away with a few action items and ideas on how you can move behavioral health integration forward. We recorded today's session, so we'll send out the recording link as well as a PDF of the slide deck and all of the links that were shared today as well. So we'll get that out early next week. And then we hope you can join us next month for the next Community of Practice workshop. And if you have a project or program that you would like to share with this community as well, our proposal form is open, and I will go ahead and put that in the chat. We're always looking for new work programs, curriculums, whatever it might be to share with the community. So thank you all again for your participation today, for sharing. And thank you, Christina, again, for a fantastic presentation. I really appreciate everyone's time on this Friday afternoon. So have a wonderful weekend, everyone.
Thank you. Take care.
Bye. Thank you.